All right, so today we'll start talking about coronary arteries. So the easiest way to understand the coronary artery anatomy basically is this circle and half loop model. So here, if we, this is a left anterior oblique projection here. So we have the left anterior descending coronary artery that would run in the anterior interventricular groove between the right ventricle and the left ventricle. And then back behind the heart in the posterior interventricular groove, you have the posterior descending artery. And then in the right atrioventricular groove, you would have the right coronary artery, and in the left atrioventricular groove, between the left atrium and the left ventricle, you would have the circumflex coronary artery. And then this is a right anterior oblique projection. So here you would see the LAD in profile going down like that, and then the posterior descending artery would be back here. So this is in the anterior interventricular groove. This is in the posterior interventricular groove. And then the right, of course, is and left are oriented in that fashion. So here is a volume rendered view of the heart from a CT in a left anterior oblique projection. And you can see here we look right down the interventricular groove. So we're looking at the left anterior descending coronary artery coming towards you. Here's the left ventricle on this side. Here's the right ventricle on this side. And then a lot of this terminology was from coronary angiography. So in this view on a coronary angiogram, when you look at the left circumflex coronary artery, it makes an obtuse angle here. And so that's why the branches from the circumflex are called the obtuse marginal branches. And then here, when we look at the right coronary artery coming around the atrioventricular groove, here it makes an acute margin. And so this is why the branches here coming off of the right coronary artery we would call acute marginal branches. Okay? All right, so let's start with this case. So over here, what vessel is this guy? Yeah, so that's the right coronary artery. Now I have vessels labeled A and B. So what is vessel A? What is vessel B?
A is the conus.
Yeah, so A is the conus branch. So that goes anteriorly towards the outflow tract of the right ventricle. And then vessel B is what?
SA nodal.
That's the SA nodal branch. Now how do you recognize that as the SA nodal branch?
It's going like posterior.
To what structure? Where does it go? The key is it goes into the interatrial septum, and that's where the SA node lives. So the vessel that goes posteriorly towards the interatrial septum and into the septum, that's going to be the SA nodal branch. Now, what is the significance of the conus branch in the setting of obstructive coronary artery disease? Why does the conus branch become important if you have obstructive disease?
Collateral.
To what? Collateral to LAD. The most common vessel to give rise to the SA nodal artery is RCA, right. The second most common, circumflex, the circumflex coronary artery. Now the vessels that we kind of mentioned this already, the vessels that supply the wall of the right ventricular myocardium, we call those acute marginal branches, right? And then what determines the dominant coronary artery? The vessel that gives rise to two things. The vessel that gives rise to the posterior descending artery and supplies what? In addition to the PDA, it also supplies the posterior wall, the posterior wall of the left ventricle. Right. Okay, so going through the anatomy, the right coronary artery travels in the right atrioventricular groove, and then we have the conus branch that goes anteriorly here towards the outflow tract. So that can be a collateral to the LAD. Remember, the LAD runs in the anterior interventricular groove, so it's headed towards the LAD. And then that collateral pathway has a name. It's called the circle of Vincennes. Okay? So about 70% of the time, this branch that goes posterior from the proximal right coronary artery, or the SA nodal branch, comes off from the proximal right coronary artery and hits towards the interatrial septum. 30% of the time that comes from the circumflex coronary artery. Okay? Now, as the right coronary artery comes around in the atrioventricular groove, it supplies branches here that supply the right ventricle. Those are called acute marginal branches. The largest one you might call the acute marginal artery. So those are the acute marginal branches. And then in most cases, the right coronary artery is dominant. So when the right coronary artery goes all the way around to the back of the heart, that's called the crux of the heart, there it can give rise to the posterior descending artery, and this guy travels in the posterior interventricular groove. Okay? But also the rest of it, you see it curves this way as it goes up like that. So that's called the crux artery here. And then right there, it continues to supply the posterior wall of the left ventricle. And then there's this branch that comes from the bend right here, and that's the AV nodal artery. We don't always identify that on coronary CT, but sometimes you can identify the AV nodal artery. Okay, so is anybody on at St. Barnabas? Yes or no? Beth Israel?
Yep.
Is somebody there at St. Barnabas?
Yes, but
Okay, so this is the left main coronary artery here. What is vessel A? This guy right over here. See, this is LAD, and then we have this tiny guy coming off the LAD. What is that guy? All right, so that's a septal perforator branch, right? That goes into the interventricular septum. Here's the circumflex coronary artery here. What is vessel B? What is this guy? So what vessel is that? No, this is off the LAD, right? This is the LAD, so that vessel B would be a diagonal branch. Okay? So, well, actually it's D2. D1 is obstructed here. You see, there's an obstruction here in D1. What is vessel C? You guys?
Ramus?
Yes, that's a ramus intermedius. Yes, notice here that there's a trifurcation of the left main, and this is a common variant, is that there can be a trifurcation of the left main with the circumflex LAD and ramus intermedius, okay? And in about 20% of cases, you can have a trifurcation with the ramus intermedius. Okay, so is anybody on at Beth Israel? No? All right, so we're back here. What is this guy? So let's start with the easy one. This guy is what?
Left corner.
Left
Main corner.
main. That's the left main. This guy, that's the LAD. This guy, circumflex. What is this guy then?
SC nodal.
Yes. So again, you have a branch that's going into the intra-atrial septum here, right? So here's the SVC. Right below that will be the right atrium. The left atrium is here. So that's headed towards the intra-atrial septum. So that is the SA nodal branch. This is one of those 30% of cases where the SA nodal artery comes off the circumflex coronary artery, okay? So let's talk about the anatomy now of the left coronary artery. We have the left main coronary artery that's going to divide into the LAD and the circumflex coronary artery. So the LAD runs in the anterior interventricular groove, and then it supplies the small branches that go down into the interventricular septum. Those are called the septal perforators. And then you have these branches that come off that supply the anterior wall, the left ventricle. Those are called the diagonal branches of the left coronary artery. The circumflex coronary artery travels in the left atrioventricular groove. In about 30% of cases, you might get the SA nodal artery that comes off of that. And then these branches come off to supply the lateral wall of the left ventricle. Those are called the marginal branches. Obtuse marginals, first one is OM1, the second one is OM2. Obtuse marginal 1, obtuse marginal 2. So if you look at a conventional angiogram, the usual projections are RIO and LAO. Here you're projecting the right coronary artery. It's a right anterior oblique projection. So here you can see the right coronary artery coming down like this. These branches coming off here, supplying the side there of the right ventricle. Those are acute marginal branches. This guy in the back going all the way down is PDA, right. And then here, looking at the right coronary artery in the left anterior oblique projection, And again, here's the right coronary artery coming around, and then down here, the PDA would be coming towards you. Okay, so that's why it looks shortened in that view. Now when we look at the left coronary artery here in a right anterior oblique projection, this guy here is going to be LAD, right? So this guy over here is going to be circumflex, right? And then these branches coming off the circumflex are going to be obtuse marginal branches, right? Now in this view, the left anterior oblique view, now the LAD is coming towards you. You see it coming down like that. So this guy over here, this is going to be the circumflex. Now these small branches coming medially in this view, right, from the LAD, these are going to be what? Septal perforators, right. These guys here are going to be diagonals, right. So in this view, the septal perforators go medially and the diagonals would be going laterally as the LAD is coming towards you, okay. There's some variation here when we look at CT on the left main coronary artery. It can be very short, as in this example. It can be longer, as in that example over there. Here we have a right coronary artery. Here there's a separate origin for the conus artery here, so there's some variation in this. And then here we can see the left vein coming down and trifurcating. There's the circumflex, there's the ramus intermedius, and here is the LAD. Now when we look down lower, almost a four-chamber view here, you can see where the vessels run. The right coronary artery runs in the right atrioventricular groove, right atrium, right ventricle. The left anterior descending artery here runs in the interventricular groove between the right ventricle and the left ventricle. The circumflex coronary artery here runs in the left atrioventricular groove between the left atrium and the left ventricle. And then this guy over here, GCV stands for great, yeah, so great coronary, great cardiac vein. And we can see the veins also, but notice that they're not as bright as the arteries because the CT scan is timed for the arterial phase. So you might see a little bit of the veins. The veins are usually larger, but they're not as bright as the arteries because the scan is timed for the arterial phase to look at the arteries, okay? And then here's an example, volume rendered view. We're looking here at the lateral wall of the left ventricle. So here you can see the trifurcation, the LAD, ramus intermedius, and then here's the circumflex coronary artery. So you can see a ramus intermedius in about 20% of cases, okay? And then we looked at this already. A branch going anteriorly would be the conus branch from the right coronary artery, this guy over here. And then the branch going posterior, this guy over here. So that would be the SA nodal branch, all right? So we talked about this at the very beginning, okay? So as we're looking at this volume rendered view now, we have the right coronary artery coming around here in the right atrioventricular groove. We have this branch going back posteriorly. That's going to be the SA nodal branch. This guy coming anteriorly is going to be the conus branch. Look how close it is to the LAD. That's why you can develop collaterals there. Okay, these guys are going to be, yeah, those are acute marginal branches. Here on the left side, this guy is LAD. You can see the diagonal branches, and then these guys going down into the septum. Those are septal perforators. Okay. All right. So, is there anybody there at Beth Israel yet? Yes or no? Yes. Okay. So, tell me, what is vessel A? What is vessel B? Yes. So the easiest way to handle volume render views is to realize the projection you're looking at and to identify the chambers, right? So if we're looking at we're saying we're looking at the crux of the heart. So what view is this? Are we looking at an anterior view or a posterior view? Posterior view, right. So this chamber would be left atrium, this guy. That makes sense. I mean, it's a little bit bigger than this guy, which would be this guy. Right, so we're looking at the back of the heart. So this guy coming down here in the back of the heart between the ventricles, you said that's going to be PDA. So this guy is what? That is the RCA, right. Now, what is vessel B? What is this guy? Any, no, no.
Posterior left.
It's the posterior left ventricular branch. It's supplying the posterior wall. See, it's going to the posterior wall of the left ventricle. Remember, dominant right coronary artery gives you a PDA, and there's a branch that continues as a posterior left ventricular branch, okay? All right, so there can be some variation there. Sometimes you don't have a well-defined PDA. In this example, there's more than one vessel you see here going towards the PDA territory. So you might have this also, where there isn't one well-defined PDA, but there are multiple vessels here going towards the PDA territory. It's still a dominant right coronary artery. You could see it's still supplying the PDA territory and still supplying the posterior wall of the left ventricle, okay? Now, I don't expect you to memorize this, but there is segmentation with a numerical system for the segments of the coronary arteries. So this is also, out there that can be used in research studies where the segments of the coronary arteries are formally numbered. But this you should know, and this is how we segment the coronary arteries when we're describing coronary CTAs. And again, this kind of description comes from coronary angio, dividing it into proximal, mid, and distal. So for the right corner, so if there's a lesion, you want to be able to describe whether it's in the proximal, mid, or distal, coronary artery. So this is how we divide them. So the proximal right coronary artery is from the origin halfway to the acute margin. So the acute margin is over there, right? So halfway, that's the proximal coronary artery. Mid-coronary artery is from that point to the acute margin, and the distal coronary artery is distal to that, okay? And then for the LAD, the proximal LAD is from the origin to the first septal perforator. The mid-LAD is from that point halfway to the apex of the ventricle, and then the distal LAD is from that halfway point there to the rest, to the apex of the left ventricle. So that's a segmentation of the LAD. So segmentation of the circumflex, the proximal left circumflex is from the origin to the first obtuse marginal branch here, and the distal circumflex is distal to that. It's not unusual for the obtuse marginal to be larger than the continuation of the circumflex. The circumflex could turn into a small vessel as it heads distally there in the left atrioventricular groove. And then you can have a wraparound LAD sometimes where the LAD comes around and wraps around the apex of the ventricle, as in this case, to supply a little bit of the posterior wall, or a little bit of the, towards the interventricular septum posteriorly, the posterior interventricular groove. And then sometimes you might have separate ostia. Here the LAD and the circumflex, we're looking from the top down, so this is the left side, this is the right side. So you can see that we have separate ostia for the LAD and the circumflex coronary artery. So those are all variations that we might have. Okay, so over here, which one of these answers is correct? So what kind of view is this? What are we looking at? Are we looking anterior posterior? We're looking posterior, right? So this chamber is this chamber. So what is this guy? That's the circumflex. So what is this branch? PDA, right. So, and then this branch here is a posterior left ventricular branch, all right? So in this case now, we have the left coronary artery supplying both of these vessels, so this would be this is a dominant left coronary artery. And then here on the axial view, we're looking at the bottom of the heart. We can see the circumflex coming around here, and then here it's supplying the inferior wall of the left ventricle, and then here is the PDA. Here's a volume render view showing you the same thing here. Here's that branch supplying the posterior wall of the left ventricle. That's this guy over here. And then here is the branch, here's the PDA. So this is a dominant left coronary artery, okay? And then here on this view, what is this now? What are we looking at here? This is codominant, right? So again, what view is this? That's a posterior view, okay? So this guy over here is circumflex, and this branch is posterior left ventricular branch. This guy over here is RCA, and this guy is PDA, right. So here you have the PDA coming off the RCA and the posterior left ventricular branch coming off the circumflex coronary artery. And then here on the volume render view, you can see two vessels actually, one from the right and one from the left coming towards you. One of these, so you have PDA and then posterior left ventricular branch. So this is codominant coronary artery, okay? So in most cases, the right coronary artery is dominant 80%. You can have a balanced or codominant system in about 11%, and then left coronary artery dominance occurs in about 9%. Right coronary artery dominance is most common, so the right coronary artery comes all the way around to give you the PDA and continues to supply the posterior wall of the left ventricle. When we have a balanced or codominant system, the right coronary artery ends at the PDA, the circumflex continues around to supply the posterior wall of the left ventricle, and then when you have left coronary artery dominance, you will have the left coronary artery going around to supply the posterior wall and to give you the PDA. So that's left coronary artery dominance. So dominant left coronary artery here, we have the circumflex. We're looking at the back of the heart, so we have the circumflex coronary artery coming around, supplying the posterior wall of the left ventricle, and then here we have PDA coming down along the posterior interventricular groove. So dominant right coronary artery, this is what we usually see. We're looking at the undersurface of the heart here. The right coronary artery comes around, supplies the posterior descending artery, and then here we have the posterior lateral branch, which continues to supply the posterior wall of the left ventricle. Dominant left coronary artery circumflex comes all the way around, gives you the posterior lateral branches here, the posterior left ventricular branch, and then PDA coming off the circumflex coronary artery. Now, there's an easy way when you're just looking at the axial images to spot the dominant vessel. Who can tell me what the easy way is?
So you look at the atrioventricular groove and
Right.
compare the size of it.
You look at the atrioventricular groove and you compare the size of the arteries, okay? So here you see the right coronary artery is small in the atrioventricular groove, but the circumflex coronary artery is larger, okay? So in a right dominant system, the right coronary artery is usually larger or should be larger. So here you would suspect that this person has a left dominant system, and indeed the left coronary artery, the circumflex, continues all the way around to supply the PDA. So if you just look at the atrioventricular grooves and you compare the size of the right and the left coronary arteries, okay, you can determine pretty quickly, which is going to be the dominant vessel. Again, this is a coronary vein. It's usually larger and not as dense as the accompanying vessel. Okay? All right, so dominant left coronary artery, we have the circumflex coming around, supplying the posterior wall and giving you the PDA. Codominant right coronary artery comes around, gives you the PDA, and the posterior wall of the left ventricle is supplied by branches from the circumflex coronary artery. Okay? And so that's the case we looked at here. You see two vessels here along the posterior part of the heart. This one coming off the right coronary artery here, that would be the PDA, and then the one coming off the left is supplying the posterior wall of the left ventricle. So that's a codominant system. Okay, so you guys over here, see the arrow is pointing to this vessel. Okay, see that vessel? What is that vessel? This guy over here is the posterior left ventricular branch, okay? And now for this slide, what is this vessel here? You guys? Yeah, so that's the AV nodal branch. Notice. Okay. All right, so this is the AV nodal branch here. So we said that as this comes around, we have the right coronary artery, PDA. This branch continues the posterior wall of the left ventricle, and then this guy coming off is the AV nodal branch. Okay. Now why is it doing this now? There we go. Okay. All right. So you guys over here, we're looking at a posterior view of the heart. So let's name these vessels. What is A, what is B, and what is C? What is A? Yeah, so A is the coronary sinus. So now we're looking at the veins. So the coronary sinus here empties into what chamber? The right atrium. Yeah. And so this guy here is, C is what? Posterior interventricular vein, right? So that runs alongside here, the posterior descending artery, and then vessel B is great cardiac vein. Okay, so this is the posterior ventricular vein, is also called the middle cardiac vein. All right, so we're looking at the veins: coronary sinus, great cardiac vein, and middle cardiac vein, or posterior interventricular vein. All right, so these are the coronary veins. There's also an anterior interventricular vein, so this runs parallel to the LAD. All right, so the coronary sinus we've covered before, drains to the right atrium via the BCM valve. We have the great cardiac vein, which is a continuation of the coronary sinus here in the left atrioventricular groove. And then there's the anterior interventricular vein, which runs in the anterior interventricular groove alongside the left anterior descending coronary artery. The middle cardiac vein runs in the posterior interventricular groove along with the PDA. All right. So another volume rendered view of coronary veins. And the coronary veins can become important because what device might they place through the coronary sinus? Yeah, pacemaker for what? No, it's a pacemaker to pace the left ventricle. If a person has left bundle branch block, usually the pacemaker paces the right ventricle and that paces the left ventricle. But if there's a left bundle branch block, then you can't pace the left ventricle through the right ventricle. So they would place a pacemaker lead through the coronary sinus into one of these coronary veins alongside the left ventricle, and then that lead then would, right up against the myocardium of the left ventricle, that lead would be used to pace the left ventricle in those cases. That's why we'll see those leads, you'll see those pacemakers with a lead in the right atrium, lead in the right ventricle, and then lead going through the coronary sinus into one of these veins. So that's for biventricular pacing. Okay. Now, when you look at these veins, it's easiest to decide when you identify the accompanying artery. Okay. So this artery is what? LAD. So this guy would be, yeah, anterior interventricular vein. And then over here, right? So this guy would be circumflex, so then that would be, yeah. So great cardiac vein will run alongside the circumflex, and the anterior interventricular vein would run alongside the LAD. This one is heavily calcified LAD over there. Okay. So when we look on coronary CT at the coronary arteries, we have these reconstructions that we can do. These are kind of curved multiplanar reconstructions. We like to look at the right coronary artery here coming around, so we'll reconstruct it this way. We'll run a center line going through the coronary artery, and then you'll see it comes around. We can have it come around like that, and then manipulate it, in different ways. And then here you'll see the PDA coming towards you. And then here we're looking at kind of a two-chamber view, left atrium, left ventricle. Here's the LAD coming down the anterior interventricular septum, and then for the circumflex coronary artery, we can see it wrap around like that, wrapping around the left atrioventricular groove. Okay, so let's discuss coronary anomalies. So over at Beth Israel, what is this? Yeah, so what vessel is this? LAD. What's the significance of a myocardial bridge? Yeah, if it's a deep bridge, but in most cases, myocardial bridges are asymptomatic and incidental findings on CT. Okay, the most common location for a myocardial bridge is right where you see it here in the mid-LAD. So the mid-LAD is the most common location to find the myocardial bridge. And then what can happen is, here we're looking at diastole and systole, is And with coronary angiography, you can't see the myocardium. So how did they diagnose a myocardial bridge? Well, you can see during systole that there's what's called milking of the vessel. The vessel kind of collapses and gets smaller as the myocardium around it contracts. So that's how they identify a myocardial bridge on conventional angiography. Then you'd have to do retrospective gating to actually see the vessel narrow like that during systole. Okay, so in some cases, if it narrows enough, it might cause ischemia. But in most cases, myocardial bridges are incidental findings. So we can have, most bridges are superficial, but sometimes you can have deep bridges. So if it dives deep into the myocardium greater than 3 millimeters, or if it takes a bend, as you see here, those are the ones that are more likely to be symptomatic, the deep myocardial bridges. Okay. Then here on a volume render view, you can see the coronary artery actually disappears because on this volume render view, you can't see through the myocardium as the bridge, as the coronary artery dives down into the myocardium there. So that's a deep myocardial bridge. Okay, so you guys over here, what abnormality are we looking at? And what's the significance?
Malignant scores. The LAD scores between the aorta and the pulmonary.
Okay, so this vessel is actually the left coronary artery, okay? And you said that the course was, so what do we call this course? If it's going between the aorta and the pulmonary artery, that is called interarterial course, right? And those are the courses that are more likely to be associated with ischemia. So here we have the left coronary artery. It's an anomalous origin of the left coronary artery. It's coming off the right, but as it's going across, it's going between the aorta and the pulmonary artery, and then it can get squeezed in that location between the aorta and the pulmonary artery, so that can be associated with ischemia. That course is called an interarterial course. So when we're talking about anomalous origin of the coronary arteries, the most common is to have the circumflex come off the right coronary artery. But this, most commonly though, it takes a retroaortic course. It goes around the aorta, which is a benign course. So this course is not associated with ischemia. So that anomalous circumflex from the right going behind the aorta is the most common and not associated with ischemia. So if you have a coronary artery that goes between the aorta and the pulmonary artery, here's an anomalous right coronary coming off the left. If that goes between the aorta and the pulmonary artery, that can be a malignant course that can be associated with ischemia. Here in this diagram is an example of the right taking a retroaortic course going behind the aorta. So that is a benign course. As long as it doesn't go between the aorta and the pulmonary artery, that is considered a benign course. So whether you have anomalous left coming off from right or anomalous right coming off from the left side, the key is, does it go between the aorta and the pulmonary artery? If it goes between those two vessels, it can get squeezed and that can lead to ischemia, so that is a malignant course, okay? So, anybody at St. Barnabas? All right, so what are we looking at here? Yes, so this is an anomalous circumflex coming off the right coronary artery. This is going behind the aorta. You can see that going behind the aorta. So that's your retroaortic course. That is a benign course. Okay. So, and as I said, this is the most common anomalous origin that you see in clinical practice is the left circumflex coming off the right. But fortunately, it goes behind the aorta. So that's a retroaortic course. So that is considered a benign course. Okay, and then here's a volume rendered view looking from the top. So that's why the right is here and the left is here. So looking from the top down, we can see the circumflex coming off the right, going behind the aorta, and then winding up in the atrioventricular groove. If you get confused in trying to decide what vessel you're looking at, look at where the vessel winds up. Okay, so this vessel that winds up here in the anterior interventricular groove has to be the LAD. This vessel here that winds up between the right atrium and the right ventricle, that's the right coronary artery. This vessel here that winds up between the left atrium and the left ventricle, that's going to be the circumflex coronary artery. And we follow that back and we see it comes off the right, but it takes a retroaortic course. Okay. There's another course that is also a benign course, and that's if the vessel goes in front of the pulmonary artery. That's called a prepulmonic course. So you could have an anomalous origin of a vessel, and it might go in front of the pulmonary artery to go to its territory. That is also a benign course. So a prepulmonic course is also considered a benign course. Okay, so you guys over here, what are we dealing with in this case? So here we have this vessel, right? This anomalous right coronary artery, and it's coming off the left. What about the course? So we call this course interarterial. This view, this kind of sagittal view where you can see the aorta and the pulmonary artery is very useful because here you can see the anomalous vessel. And there it is as it's going across here, you can see it's between the pulmonary artery and the aorta. And you can see how it can get squeezed in that location. So that's a malignant course. Okay, so we have the right coronary artery coming off the left, taking an interarterial course. And this reconstruction, that sagittal reconstruction, showing you the vessel and its relationship to the aorta and the pulmonary artery is very useful for identifying that course. And then here on this volume rendered view, you can see the vessel coming across, going down between the aorta and the pulmonary artery, and you can see how it can get squeezed in that location. Now, here we're looking at systole and diastole, and you can see how it can get narrowed there. It can get narrowed during systole. And another important thing about the course is if it hugs the wall and it has a slit-like orifice like this, and this also you can identify on CT. So if it takes this acute angulation and it hugs the wall, then this is also intramural. It's actually traveling in the wall of the aorta. And that can further aggravate the obstruction here at the origin, the slit-like orifice, the angulation, and that intramural course as it wraps around the aorta can aggravate the obstruction of this type of anomalous coronary artery. Now, there's one other thing about these interarterial courses when you have the anomalous right coming off the left. If the origin is above the pulmonic valve, that's called the high interarterial course versus the origin being below the pulmonic valve, the low interarterial course. The high interarterial course is more dangerous, okay? So if the origin is above, when you have this vessel, the anomalous right coming off the left going across, if the origin of that vessel is above the pulmonic valve, that's considered a high interarterial course, versus the origin being below a low interarterial course. And when they look at the studies, so the chest pain and cardiac events are much higher in those patients where that anomalous right coronary artery coming off the left has a high interarterial course. Okay, so that's something else to realize when we're looking at these vessels. This is another example of what anomaly. You see this guy going around, and then here on this reconstruction, here's the pulmonary artery, here's the aorta, here's the anomalous vessel. So what anomaly are we looking at here? Yeah, so again, we're looking at an example of the circumflex coming off the right, going behind the aorta. So remember I told you that that is the most common anomalous origin that you will see, the anomalous circumflex coming off the aorta, going behind the aorta, taking a retro-aortic course, okay? So, over at Beth Israel, what anomaly is this? Yeah, so this is the LAD coming off the right. What's the course? What do you call this course? Is this a malignant course? So is this a malignant course? Guys? going through the myocardium, it's going through the interventricular septum below the vessels, okay? So this is not a malignant course, this is called a transeptal course. This is a transeptal course. If it dives down below the valves and goes through the myocardium, that's called a transeptal course. That is a benign course not associated with ischemia. So if the vessel takes a course through the interventricular septum below the valves, that's a transeptal course that is not associated with ischemia. So in summary, what is it that we need to know about these anomalous courses? The only bad one is the interarterial one, where the vessel is actually going between the aorta and the pulmonary artery. If it goes in front of the pulmonary artery, that's a prepulmonic course, that's benign. If it goes behind the aorta, that's a retroaortic course, that is benign. If it takes a transeptal course, if it dives down and goes through the interventricular septum, that is also a benign course. That transeptal course is also a benign course, okay? All right, so let us, now, not that you need to memorize the diagram, but whether both of those, whether it's an anomalous right from a left or an anomalous left from a right, so both of those can get the patients into trouble. But it turns out that the anomalous left coming from, or the anomalous left taking an interarterial course is worse than an anomalous right taking an interarterial course. So there seems to be some recommendation out there that these patients with an anomalous left taking an interarterial course will require some kind of treatment, whereas those patients who have an anomalous right, as long as they don't have symptoms or arrhythmias, that it's a little bit more controversial whether you need to do anything about that. So the direction seems to be, if it's an anomalous interarterial right coronary artery, as long as the patient is asymptomatic, they don't necessarily have to do anything about that. All right, so this is a 25-year-old woman who has chest pain, and she has a big heart here on the chest radiograph, and of course that means she gets a coronary CTA. So, Sam, what do you think of the CT here? So you could see the coronary arteries are they're dilated, right? By the way, what is this guy? See that guy? Yeah, that's the conus, and it's going to where?
The LED,
Right, so we call that
circle of descent.
the circle of descent, right? So you can actually see a collateral there in this particular case. All right, so we have dilated coronary arteries. What are you thinking about?
There's probably maybe like a fistula somewhere maybe, or.
Okay, so one thing that could cause dilated coronary arteries is if there's a coronary artery fistula, right? That can give you dilated coronary arteries. Is there anything else that can give you dilated coronary arteries?
Working out.
No. Yeah, so vasculitis. Vasculitis can be associated with dilated coronary arteries, right? So those are some things that you might consider. So for this particular case, we have some more imaging. So tell me what you think.
So it looks like on the image on the left, it looks like the circumflex artery is.
Talking about this guy?
Yeah, left circumflex?
Well, this guy is this guy, and I'll tell you, it's hard to tell on here. That's the left main.
Oh, okay, left main. So the left main is really dilated, and it
Yes.
looks like it's coming off of the pulmonary artery.
Yeah, so this is the aorta here, right? And this is the pulmonary artery. So we have the left main here coming off the pulmonary artery. So what do we call that?
Al Kappa.
Al Kappa, right? Anomalous left coronary artery from pulmonary artery, right? And so the problem here is what then? What happens?
There is flow from the higher pressure system into the lower pressure system, so from the LAD into the pulmonary artery.
Yeah, so the flow is actually reversed, right, in this vessel because it's following the pressure gradient towards the pulmonary artery. And then that's why we develop all of these collaterals and dilated vessels from the right coronary circulation, right coronary artery to the left. So this is a nice example of anomalous origin here of Al Kappa. So this can be associated with ischemia in infants. And as we've said, what happens because of the pressure gradient here is that the flow is actually reversed in the left coronary circulation. So these patients develop collaterals from the high pressure coronary arteries to the anomalous left coronary artery, and then the blood flow then goes towards the pulmonary artery. And so that can result in ischemia because it robs the blood flow from the myocardium. So here's an angiogram in that case. So here we're injecting the right coronary artery. You see all of the collaterals from the right coronary artery to the left coronary artery, but then there's reverse flow here as it opacifies later, and you can see it's dumping into the pulmonary artery back there. Okay, so that's the problem. Big heart because of failure. Here you can see the collaterals from the right to the left, reverse flow in the left going into the pulmonary artery in these cases. So the presentation, whether it presents during infancy or early adulthood, has to do with the status of the collateral vessels. So if the collateral vessels are not well formed, then these patients will present with ischemia, ischemic symptoms during infancy. If the collateral vessels are well formed, it can be clinically silent until adulthood, as in that particular case. So over time, the collaterals, can't keep up with the oxygen demand, and so patients can develop arrhythmias, ischemic cardiomyopathy, mitral insufficiency as the heart dilates, and it's also associated with sudden death. Okay? So left coronary artery from pulmonary artery. Notice all of the coronary arteries are dilated in cases like this because of that collateral flow from the right circulation to the left, and then you have all of these dilated vessels, all of the collateral vessels that we can also see in these cases. And so sometimes if you happen to catch it just right, you can actually see the direction of flow of the contrast. You see the contrast is actually going into the pulmonary artery here in this case. And then here's an MR showing diffuse subendocardial enhancement, representing actually, partial thickness infarction, global infarction there, partial thickness involving the left ventricle because of the ischemia. Okay. All right. So is there anybody on at St. Barnabas? No? Anybody at Beth Israel? Nobody's admitting to it? Okay. All right, so it's you guys again. Cosmin. So, what vessel is being injected here on this coronary angiogram?
Is it the circumflex?
Well, let's see. This vessel is going this way. This vessel that's being injected is going this way, right? And then it divides into two vessels. So what is this vessel?
Left main?
Yeah, so the left main there is injected with contrast. So what vessel is this guy?
That's the circumflex.
Well, first of all, think about the projection, okay? What projection do you think this is?
Is this left anterior leaf?
No, the heart's on this side.
So right anterior leaf?
Yeah. So if it's a right anterior oblique, right? So then the vessel in profile here is going to be what?
The LED.
Right. And so this guy will be the
circumflex.
correct. Now you can see that there seems to be some problem here, right? Coming off of the LAD, right? See that?
Yes.
So we're going to take a look at so I want you to take a look here at the LAD on this CT, and you tell me what the problem is.
Is there a connection to the main pulmonary?
Yeah,
artery?
correct. So as we're going through this, here's the LAD, comes down there, right? And then we see that there's this funny looking branch that comes off of it and then connects to the pulmonary artery. So when you go back to the angiogram here, okay, that's this vessel here, and that's why you see all of that funny looking contrast here. It's going into the pulmonary artery, okay? So what do we call this?
Fistula?
Yeah, so this is a fistula. So this is an arteriovenous fistula. Here is that these vessels, the ones that are involved, usually kind of get tortuous like that. So that is the vessel there on the volume rendered view, and then here we can see the connection with the pulmonary artery in that case. Okay. Now, here's an example where, now notice, as opposed to when there's anomalous origin of a main vessel off of the pulmonary artery, when all the vessels dilate, here when there's a coronary artery fistula, only certain vessels will dilate, will be involved. So in this example, why is the right coronary artery dilated? So it's the right coronary artery there, and it's dilated down to there, dilated to here, and here it is going around the right atrium. So what's the problem here? Why is the right coronary artery dilated?
Connected to the coronary sinus?
Yeah, you can see it's going down here and it's connecting to the coronary sinus, okay? So that's another example of a coronary arteriovenous fistula. And so again, because of the high flow that's going to be going through that, because of the pressure gradient, the vessel dilates. And again, it can result in ischemia. All right, so that's a fistula right coronary artery here coming around going to the coronary sinus. So a coronary arteriovenous fistula, it's a fistula from the coronary artery to a coronary vein, coronary sinus, right atrium, right ventricle, pulmonary artery. So notice it's going to areas of lower pressure, most commonly right coronary artery to right atrium or right ventricle. So here you can see a fistula there dumping into the right ventricle. So the involved coronary artery is usually dilated and tortuous, and even though there's a little bit of a left to right shunt, that's usually small. The problem is the ischemia because of the all of the blood flow that winds up going through the fistula. Most commonly, these involve the right coronary artery, left coronary artery is the second most common. Sometimes it can be both. So a coronary cameral fistula is the technical name if it drains to a chamber, a coronary arteriovenous fistula if it drains to a vessel. And right ventricle is the most common site. Second most common is right atrium. Then you have pulmonary artery and coronary sinus. So those are all examples of that. Here you have a dilated left circumflex coronary artery, and then that's because it's draining to the right atrium. Okay. And so here's a left circumflex in this case coming down, draining to the right atrium. And then here's another example. So again, these may present in early adulthood because of myocardial ischemia. Coronary steel can also be associated with endocarditis, sometimes AFib. Rupture is pretty rare. So the involved vessel will be markedly dilated, as in this example. Notice the other vessels are kind of normal in size. And so here's a volume rendered view, is a large right coronary artery fistula here. Going back into the right atrium. Right? So whenever we see a tortuous dilated vessel like that, think about a coronary arteriovenous fistula.
I have a stupid question.
Yeah.
Why physiologically does it get bigger if it's just dumping in? Because it's not like flow is reversed into the dilated coronary.
There's increased flow through the vessel because of the decreased resistance. There's a lot more flow that's actually going through the vessel.
Oh, so it's not.
And again, it's been there congenitally, right? So it's been there. It's not something that just occurred.
Right.
So it's been there for a long time, which allows it to just get bigger and bigger. Okay. All right. So this case here, we have a 19-year-old woman with chest pain. What do we think is abnormal here? Well, let's look at some of the vessels here. So this guy here is what? What's that vessel?
Main.
That's the left main. This guy,
LED.
LAD. This guy here,
Circ.
This guy,
Intermediate.
right, that's the ramus intermedius. This vessel over here, what's this
Right.
vessel?
Acute marginal.
This guy,
Oh,
that's
yeah.
the RCA,
Right.
right. And then this guy over here might be the
SA.
SA nodal branch, this guy conus, right? So where's the aneurysm?
Right corner.
So there's an aneurysm here at the
There's
right,
two of them.
proximal right, and where's the second one?
The LED,
LAD.
bifurcation, like.
Well, what is this guy? That's a
Diagonal.
diagonal, right? So there's an aneurysm there in the LAD near the origin of the first diagonal here. Okay. So what could do this?
Kawasakis.
So vasculitis like Kawasaki's can be associated with multiple coronary artery aneurysms. What else might cause coronary artery aneurysm? Well, the most common cause of
Cocaine.
coronary. Yeah, so drugs like cocaine can result in coronary artery
Sorry, is that too
aneurysm.
enthusiastic? That was-
In the United States, the most common cause of coronary artery aneurysm is what? Atherosclerosis, right? But you wouldn't expect that in this age.
Lame.
There's one other thing that you might also consider for coronary artery aneurysms, mentioned earlier, when we talk about dilated coronary arteries, you said
Vasculitis.
vasculitis, right? So that can also be. So those are major things that can be associated with coronary artery aneurysms. I guess another thing to think about if the patient had positive blood cultures,
Endocarditis.
mycotic aneurysms, right? You can also get mycotic aneurysms, okay? So here's the right coronary artery there, there's the aneurysm, you can see it going around. Now, here, we're looking at a CT, what kind of view is that on the CT?
Short axis.
Short axis view, so anything abnormal on the CT?
Decreased and attenuation in the endocardium of the inferior wall.
Yeah, so along the inferior wall is a perfusion defect, so why does the patient have chest pain?
Because they're having an ischemic event.
Could be ischemia, could also be an infarct,
True.
right? So why might this patient have an infarct? How might this be associated with infarction?
Ruptured.
Well, it's not ruptured. Right, so when you have aneurysms, right, you can form clots within the aneurysm and they can embolize distally. This isn't a distribution of the distal right coronary artery, okay? So emboli that form can travel distally and can cause small infarcts, as in this particular case. All right, so this is a patient with Kawasaki's, also called mucocutaneous lymph node syndrome. Is angiogram showing coronary artery aneurysm. It is a vasculitis, usually affects children. Worldwide, this is probably the most common cause of coronary artery aneurysms worldwide, is Kawasaki's. For the United States is atherosclerotic disease. The size of the aneurysm is important. Less than 4 millimeters, they usually regress. Greater than 8 millimeters, though, they can progress to obstruction or stenosis. Okay? And think about it, if you have a young person with coronary artery aneurysm, especially if there are multiple aneurysms, right? So young person or multiple coronary artery aneurysms in a young person, we think of Kawasaki disease. So the definition of an aneurysm, dilatation 50% or greater than the preceding normal artery, causes atherosclerosis, vasculitis, infection, cocaine, congenital, I guess, AV fistulas can do that also. So a few words about coronary artery disease. So we know that it's a major cause of death in developed countries. 50% of fatalities from coronary artery disease have no prior symptoms. So the first symptom of coronary artery disease is the myocardial infarct. And the reason that occurs is because these patients have plaque that forms within the wall, lipid plaque, that is unstable, and it's not encroaching on the lumen, so they don't have any signs of ischemia, but when the plaque ruptures, then it causes an acute thrombosis here that leads to the infarction from acute occlusion of the lumen. And that's called the vulnerable plaque hypothesis. So it's the deposition of the lipid within the wall of the vessel, and it's covered by a thin fibrous capsule, so this is vulnerable to rupture, and if it does rupture, then the vessel becomes occluded, and the patient develops an infarct. So rupture of soft plaque is thought to be the most common cause of myocardial infarction. Now, the natural history of plaque progression is that the plaque can actually grow within the wall, and that does not encroach on the lumen. It may not necessarily encroach on the lumen. So the patient does not have signs of ischemia. This is the vulnerable stage. This is when if the plaque ruptures, the patient can have an infarct. but over time it stabilizes and then goes on to calcify. So the older patients who have stenosis with calcified plaque, this is more matured plaque, these are less likely to rupture, although these can be associated with symptoms of ischemia, chest pain, angina, etc. Okay? So many times the culprit lesion, right, because the plaque grows away from the lumen, may not cause that much stenosis there within the lumen. So angiography may not necessarily pick up these vulnerable plaques because they're growing away from the lumen and may not encroach much on the lumen at all. Now, in terms of grading stenosis, this you do have to know that this is a fair exam question. For grading of stenosis on a coronary CTA, minimal stenosis is less than 25%, mild stenosis 25 to 49%. We're talking about diameter stenosis here. Moderate stenosis is 50 to 69%, and severe stenosis 70 to 99%. So that grading system you do have to be familiar with. That is a fair question on an exam. Now, I'm also giving you lists, this kind of a listing of distribution of where the most significant stenoses, might show up. So we talked about this already. The circle of Vincennes, we said, was a collateral from
The conus
conus to the LAD, right? Kugel's artery, it's another named collateral. This one you might see on CT. We saw an example. This one you probably won't. But Kugel's artery is any collateral vessel that goes through the AV nodal artery. So I've given you this diagram also that describes where you can have collateral flow, and it's where the arteries get close to each other, the different circulations. So you have the LAD here, you have the PDA there. So over the apex of the ventricle, you can develop collaterals. Through the interventricular septum, you can develop collaterals. Along the atrioventricular groove between the right and the left coronary artery, the circumflex and the right coronary artery, you can develop collaterals. So those are just locations where collaterals like form. And we talked about this guy, the circle of Vincennes, in our case about kappa there, the conus branch acting as a collateral to the LAD. Bypass grafts. What are the two major types of bypass grafts?
Saphenous and Lima.
Yeah, so saphenous vein graft and internal mammary artery graft. So Lima is one type, it's left internal mammary artery graft. Okay, and your examples, the saphenous vein grafts here, and in this diagram, that's an internal mammary artery graft there. So for the saphenous vein graft, they harvest the saphenous vein, attach one end to the ascending aorta, and then the other end to whatever vessel they're going to be bypassing to. For the internal mammary artery graft, the internal mammary artery comes off of the subclavian, so that's where the blood flow, how that blood gets into the internal mammary artery, and then they just dissect it off of the chest wall, and then they will anastomose the distal end to the coronary artery they're going to. Usually the LAD for a Lima to LAD is a very common internal mammary artery bypass graft. So what are advantages and disadvantages of each type?
Saphenous has greater flow.
Right, why is that?
Bigger.
It's just bigger, right. So the saphenous vein graft, because it's bigger, will have a higher flow rate.
But
Also, it gives you more options as to where you're going to bypass to, because with a saphenous vein graft, you can bypass to any vessel, right? With the Lima graft, you're kind of, or with the internal mammary artery graft, there's limitations with the anatomy about where you can bypass to. So what's the disadvantage then?
Thrombosis.
Yeah, so the long-term patency rate is higher with an internal mammary artery graft than it is with a saphenous vein graft, okay? So the internal mammary artery grafts can be the right or left internal mammary artery, and most common, as we said, left internal mammary artery to the LAD, and the flow rate is slower, but it has a higher long-term patency rate. The saphenous vein graft has a higher flow rate, but the long-term patency rate not quite as good. And then these are examples on CT. You can recognize the saphenous vein graft. It's attached to the ascending aorta here, and then the distal part just goes down to whatever vessel you're bypassing to. the internal mammary artery grafts, comes off the subclavian and then comes down and then to the LAD or any other vessel. So it's important that if, by the way, this is CT, coronary CT now is now the preferred way to image these grafts if you're trying to evaluate them for patency, okay? It is important to know if the patient has a graft because that affects your protocol. How?
Well, does it fill in diastole anymore? It fills in systole?
No,
Like not include the whole vessel?
well, yeah, you got to include the whole vessel, right? So when you're doing coronary CTA, usually we just scan the heart, right? But if you have a graft, then you have to make sure that you're above the origin of the graft. So especially if you have an internal mammary artery graft, you're going to have to start at the level of the subclavian arteries above the arch. So you have to include all of that in your scanning field. So it's very important to know if the person has any bypass grafts before you actually do your cardiac CT, okay? So this is a right internal mammary artery graft here coming down. So here it is on the CT. You can see it coming down. These are all clips distally, which sometimes interfere with your ability to evaluate these grafts. What's wrong with this saphenous vein graft? Yeah, you can see that big thrombus there within that one, right? So it's got a thrombus in it. Here's another example, thrombus there on the saphenous vein graft. So if I tell you this patient has a history of a CABG, or a coronary artery bypass graft, is there anything wrong here? Anything that you're concerned about?
There's that little, like, vessel bump off of the.
There's a little bump here, right, off the ascending aorta. So what is the significance of that?
Is it thrombosis?
What does it mean?
There's like increased pressure or something?
Well, what might have been, or what is here that you can't see?
The graft?
What graft? What kind of graft?
Internal memory?
No, they don't come off the ascending aorta, right?
Sorry, I got distracted.
Is that Narav trying to tell us something?
Saphenous.
Yeah. So that's the origin of the saphenous vein graft, but the graft is occluded now, so you don't see the graft. Okay, all you see is this little bump here, which is the origin of an occluded saphenous vein graft. So there's a term for this sign. Anybody know what the term is? Nubbin sign, right? So this is called the Nubbin sign, and it's a sign of an occluded saphenous vein graft. Okay, so occlusion saphenous vein graft, the Nubbin sign. All right, so that's where the origin of the graft is. Of course, you can't see the graft because there's no contrast in it, so we really don't see it. Okay. All right. So for this particular case, does anybody see anything they want to talk about? Well, let's okay, so let's go through the structures. This guy here is,
Left atrium.
and this guy,
Left ventricle,
this guy
right atrium,
over here,
right
this
ventricle.
guy over here. Right, so what is this guy?
RCA.
Internal memory?
Well, whatever it is, it's abnormal in size, right? So there's a dilated vessel there, so our question is, what is that vessel? Is that a big RCA, or is that something else? Is there a clue? Any other clue on the image? Right, there's sternotomy wire.
Oof.
Right?
Test taking.
Dang.
So, this patient has had what procedure then? Bypass, had a coronary artery bypass graft. So what is this going to be?
A bypass graft.
Yeah, that's an aneurysm within the bypass graft. All right, so saphenous vein graft aneurysm can occur. It could also occur in internal mammary artery grafts too.
And
But
atherosclerosis of the circ.
the circ's on the other side, but the
Yeah.
right coronary artery.
Yeah, just, more,
Okay.
more findings.
All right. That's right, you're right, there's atherosclerosis of the circ, right. Okay, so this is what happened 6 weeks later. All right. So it's really a pseudoaneurysm. okay, as it dramatically increases in size. So these are more common with saphenous vein grafts. They can occur at the proximal or distal anastomosis. So if you see any dilatation, any abnormality like that, dilated vessel along the course, that could be along the course of a bypass graft, then we have to think of a graft aneurysm. Okay? So this was a saphenous vein graft aneurysm. Now another indication for CT, coronary CT, is if these patients need reoperation, patient who's already had a CABG and needs repeat cardiac surgery for any reason. The problem is that, especially if they have an internal mammary artery graft, the graft can become adherent to the sternum. Okay? And if that's the case, then that's a contraindication to median sternotomy, because they don't want to be cutting into that doing the procedure. So another reason to do CT is to evaluate the course of the vessel to see, is it going to interfere with their surgical approach? So here's an example where it's distant from the sternum. So here a sternotomy would be okay. Here it would not be okay. All right, so that's another reason to do that. All right, so let's move on.